Okay, so we're going to talk a bit about spinal cord injuries. And let's just look at this diagram here. Look at the most common spinal cord injuries in this particular year. Cars and falls. So, vehicles, motorcycles, any car or vehicle. Falls make up 31%. Violence, 14%. Sporting injuries, 8%. So, and then if you look below that, you'll see that 80% of them are males between the ages of 16 and 30, which wouldn't be totally surprising. Males, young males, vehicles, and falls. It wouldn't be a total shock that it is very high, but that would be the age group, and the males aren't surprising because of the circulating testosterone that's occurring. 90% of them are discharged home, not to long-term care facilities. These are young people. They're managed at home. They often need a lot of help. They can be in an assortment of devices, wheelchairs. If they're quadriplegic, meaning all four limbs are paralyzed, they'll need even more help. If they're paraplegic, meaning just their legs are paralyzed, they may be able to get by with a wheelchair. So it really depends on what the injury is, and we'll get into some of the injuries. So spinal cord injuries, where the spinal cord is injured, it can affect sensory nerves, which is input coming into the spinal cord and being relayed to the brain. So whether it's pain from somewhere, sensation, temperature, that's the sensory input. It can affect the motor output to the limbs. So movement of your upper arms, movement of your your legs, and of course autonomic functions, because the sympathetic nervous system, what's called the sympathetic chain, travels along a section of the spinal cord. So you can have injury of the sympathetic portion of the autonomic nervous system, and we'll get into that in a bit. So all three can be impacted: sensory, motor, and autonomic. You can have vertebral fractures. If you say fall off a roof that's 15 feet and you land on your bottom, and you compress the vertebra upwards, you can compress multiple vertebrae. You can dislocate vertebra, meaning they're not stacked on top of each other anymore. One of them has dislocated off, and that'll damage the spinal cord. You can have partial damage of the spinal cord below the level of injury, or complete spinal cord transection at the level of the injury. It's very hard to know what's going to return at the initial time of injury, because there's often a lot of inflammation in the area. So we often don't know for weeks what's going to be permanent and what is temporary. So it's hard to know sometimes at the beginning when the injury initially comes in. And the type of disability that occurs depends on the location of the injury. Is it in the cervical spine? Is it in the thoracic spine? Is it in the lumbar spine? And we'll get into that a bit. Paraplegia means paralysis of the legs and lower body. Quadriplegia means paralysis of all four limbs. Okay, so let's, often we can figure out what the injury is just from the history, from the type of story that we're getting from either the ambulance or bystanders or the person themselves. So look at the first one. Someone who's in a car and they have to brake really hard and they fly forward I don't see a seatbelt on either, by the way. Anyways, so their neck flexes forward very forcefully. And look at the injury. So they have a dislocation of one vertebra on another, and they've torn a very, very strong ligament in the back of the neck, the posterior ligaments. So there's a dislocation and there's a ruptured posterior ligament. Okay, and that kind of makes sense with the story, this forced flexion. And of course, if you dislocate a vertebra, look at the spinal cord, the pink spinal cord in the middle that's being compressed. Okay, so the next injury is hyperflexion, so the opposite. Well, if you hyperflex, your neck is flying backwards, and the front ligament is going to tear, and you could potentially dislocate, you haven't really here, but you could potentially dislocate backwards. But ligamentous injuries can make the neck very unstable, because that's what's holding the vertebra together very strongly. So the bones are stacked, but it's the ligaments that are holding, that are providing a lot of force and strength to the vertebral column. So that's hyperextension. The next one is a really unfortunate one, that this is an axial load, it's called. It's when you have a direct force on the top of the head that then it transfers the entire energy down the spinal column, and typically this causes compression, a fracture, compression of a vertebra, and often the fragments go backwards into the spinal cord. And this is not uncommon from diving into shallow water, having something land on your head that compresses the cervical vertebra. So that's an axial load to the spinal column, causing a compression fracture. And those fragments can go backwards and compress the spinal cord. Subluxation is basically the same term as dislocation, just less concerning. So subluxing just means I've slipped a bit. So if you look at the vertebra here, not that it's great to have in your neck, but your one vertebra has just slipped a bit on another. Okay, this can definitely cause a spinal cord injury. It's not like a full dislocation though. Okay, so subluxation, maybe it's just good to know that particular word. So there's flexion, hyperextension, compression, subluxation, and typically we're talking about the cervical spine in all of these. Your neck is the most unstable part of your vertebral column. Okay, it gives you lots of movements, up, down, side to side, but it comes at a cost, and that is that it's very prone to injury. Okay, continuing on here with spinal cord injuries. So the spinal cord can be damaged at a certain level, and we'll come to looking at different levels in a minute. But initially, there's a lot of inflammation above and below the spinal cord injury. Because there's bleeding, there's inflammation. So that's why we don't know what return of function the person will get, because they may get more than we initially think, because the inflammation settles, the bleeding stops, or it might be more extensive because there's been damage that we didn't initially know of. So very hard to know at the beginning the extent of the spinal cord injury and what level will be permanent damage. So a complete transection is the spinal cord is basically completely torn at that level. So usually if we see a completely dislocated vertebra and the spinal cord is completely torn, you can be pretty sure that at that level there's no more function below that level. Partial transection is where you can have partial return of function, and that just comes with time. We can't answer all all the questions about what's going to come back and what isn't. There's just no way of predicting at the beginning. And there's two different types of shock, and I think this is really important to know. So there's the shock, so there's spinal shock and there's neurogenic shock. So spinal cord shock is just the response of the spinal cord to the injury of the spinal cord. So what happens initially, say you've fallen off a cliff, and the person has injured their spinal cord, say at T10, where they've crushed some vertebra. The vertebra have pushed back into the spinal cord. What happens acutely, initially, when they come in? Well, they've lost their deep tendon reflexes. So when we go to test their reflexes at their knee or their ankles, they're absent. So acutely in spinal shock or in a spinal cord injury, you've lost your deep tendon reflexes below the injury. And you've also lost the motor function and the sensory function below that level. Okay? As the weeks go by, the spinal cord is still severed. You still can't walk, and you still can't feel things below that level. But the deep tendon reflexes become hyper-reflexive. So they were completely absent, and that's called spinal shock, and that's usually in the first days to weeks. And as the spinal cord is no longer in shock, meaning the spinal shock has recovered, the reflexes become hyperreflexic. Okay, so spinal shock is only about the spinal cord. Neurogenic shock is all about what's happened to the sympathetic nervous system, that the chain of the sympathetic nervous system that travels along the spinal cord. And neurogenic shock is referring to the fact that when you've injured the sympathetic nerves, you don't have sympathetic supply to the heart or the blood vessels to allow the heart to increase in heart rate and to vasoconstrict the blood vessels. So what happens? You can have hypotension from vasodilation because the sympathetic nervous system isn't supplying those blood vessels, and bradycardia because the sympathetic system isn't helping to balance the parasympathetic system. So the vagal nerve isn't damaged because that's a cranial nerve 10 that comes from out of the skull. It's not part of the spinal cord. So the parasympathetic system isn't injured at all, but it's not countered by the sympathetic system, and that's where you get bradycardia from. And because the sympathetic outflow to the blood vessels is compromised and damaged, you get hypotension as well. So neurogenic shock is all about what's happening to the heart rate, and the blood pressure. Okay, so this next slide, it looks like there's a lot on it, but let's just try and simplify it. So spinal shock, it's all about the spinal cord injury and what's happening to the reflexes. That's spinal shock. Nothing to do with blood vessels or heart rate or anything. Neurogenic shock, it's all about the injured sympathetic system that follows the spinal cord down, and it's all about the fact that the sympathetic system is injured, and so you're going to be hypotensive and bradycardic. So I'm not going to go through all of these, but I think they'll make sense if we've just gone over those two concepts. Spinal shock due to an acute spinal cord injury, absence of all voluntary and reflex neurologic activity below the level, so lost reflexes, lost sensation, and flaccid paralysis, so loss of motor function. And typically what happens within days to weeks is when the reflexes return, they're hyperreflexic. Okay? Neurogenic shock is all about the hemodynamic problem. So it's the loss of the tone of the blood vessels. They're not constricted anymore because there's no sympathetic activity to them. And there's no sympathetic activity to the heart, so you're bradycardic. So what's the end result? Potential hypotension, bradycardia, inability to regulate temperature because the sympathetic system is also going to the skin. So they can be flushed skin, vasodilated skin. So they're losing heat. They're not able to regulate their temperature. Okay. So neurogenic shock is something that needs to be managed right away. I mean, for either one of these spinal cord injuries, we always immobilize them. We don't want to move them any more than they've already been moved because it may aggravate the injury that's already there. We don't want to cause more injury to the unstable area. In neurogenic shock, the big thing is okay. Well, what about airway support? So if it's a spinal cord injury that's high in the neck, that's going to affect the diaphragm. So first thing is always airway and breathing. So there's a bit of a mnemonic. I don't like memorizing things. I don't really like mnemonics, but I know some people do. So C3, C4, C5 keep the diaphragm alive. So if you have an injury C5, so cervical vertebra 5 or above, you can impact breathing because the intercostal muscles of not only are the intercostal muscles affected because those nerves come off the thoracic spine, but the diaphragm, the nerves to innervate the diaphragm and get it to contract comes from C3, C4, C5. So airway management is a big issue with spinal cord injuries. The next one is fluids. So the fluids is because if you're in neurogenic shock and your sympathetic system is affected, you're hypotensive. So you're going to need fluids to maintain your blood pressure. And you typically need some kind of pressure support with a vasoconstrictor. Phenylephrine is very good. That's an alpha-1 agonist. So it vasoconstricts the blood vessels to keep the blood pressure up. Norepinephrine is another one that keeps the blood pressure up. It's a peripheral vasoconstrictor. So a strong alpha-1 agonist. And sometimes we'll use atropine to try and get the heart rate up a bit to maintain cardiac output. So always remember ABC, airway, breathing, circulation. Okay? And there's actually ABCD, and D stands for disability. So airway we care about first, airway and breathing. Do they have an open airway? Are they able to breathe? So let's address those first. Circulation is next. What's their blood pressure like? What's their heart rate? Do they need fluids? Do they need blood? Followed by D, and D stands for disability. And disability is what's their neurological function. We don't care about neurological function until we address A, B, and C. And then we look at, okay, what's the brain injury? Are they able to move their arms? Are they able to move their legs? Okay, so we'll mention that as we go through the different slides. Okay, so still on the subject of spinal cord injuries. So when we're talking about whether it's a head injury or spinal cord injury, there's the primary injury, which is irreversible, right? So in the case of a spinal cord, the primary injury was from the trauma, and that part is irreversible. The secondary injury is, well, initially from progressive spread of inflammation above and below the severed spinal cord. And the initial treatment aims at not causing further secondary injury. So, for example, moving the patient without being immobilized, doing everything to avoid hypotension, which will reduce blood supply to the area. Hypoxia, so making sure that the O2 sat is normal so that the blood being supplied to the area is delivering oxygen. So we're always looking to prevent secondary injury. So in any trauma case, we always think of a spinal injury. If someone's had a head injury or they've been in a car accident, we always immobilize the spine until we can rule out a spinal injury, especially a C-spine injury and a head injury. So they typically arrive with a C-spine collar on until we can rule out a spinal injury. So really when we're doing ABCs, it's ABCs with spinal precautions if it's a traumatic case, right? So airway, breathing, circulation, and in brackets with spinal precautions. So the initial care is critical to minimize further injury by moving the neck or low O2 saturation or hypotension. Now remember that we tend to think of the spinal cord as going all the way down the spine, the spinal canal. It actually ends at L1 to L2. Okay, so from L2 to L5, there's no spinal cord. There's just nerve fibers traveling down, but the spinal cord is ended. And those nerve fibers that leave the spinal cord and just dangle down are called the cauda equina, which is Latin for horse's tail. And that's why we can do a lumbar puncture lower down in the spine, because there's actually no spinal cord there. It's just nerves, and they typically just move out of the way. So below L2, no spinal cord. The other thing to remember is, okay, what's controlling your diaphragm? C3, C4, C5 keeps the diaphragm alive. Those are the nerve levels that control the diaphragm. So any spinal injury above C5 is going to involve respirations and an airway issue. And lower down, this is just to remember, this one's not as important. S2, 3, 4 keeps your anus off the floor. So the lower sacral nerves supply the rectal tone. Okay, I'd remember the first one. C3, 4, 5 keeps the diaphragm alive.